Good afternoon. My name is Alan Macfarlane and I'm a consultant anaesthetist in Glasgow in Scotland, and I've been asked to talk to you today about short and long-term outcome benefits of regional anaesthesia. I'm the president of Regional Anaesthesia UK, so clearly I could be seen as being a little bit biased towards regional anaesthesia, but I'll try not to be. And my consulting fees today have nothing to do with today's talk. When I talk about any block, I like to think about the Choosing Wisely campaign, and in Scotland we have a similar campaign called Realistic Medicine. And what this really asks, first of all, is do I really need this test or procedure or nerve block? And then what are the benefits, the risks, the alternatives, and what if I do nothing? Now, we are quite rightly very good at explaining to our patients about the risks of our techniques, but today's talk is about the potential benefits. I think it's important before we look at specific benefits to think about the potential issues we have when we are studying the outcome benefits of regional anaesthesia and analgesia, because it's a jigsaw when you start to look at all the meta-analyses, because there are so many variables. We have to think about the individual patient, we have to think about the specific procedure, and we have to think about the anaesthetic variables. The first option is comparing general anaesthesia versus regional anaesthesia. And when we look at that, we know there are potential issues, for example, comparing volatile and TIVA and the potential outcome on oncological outcomes. So we have to take that into consideration. If we're looking at regional anaesthesia, we have to consider sedation, because again, we know that depth of sedation can influence postoperative outcomes such as delirium. The next possibility when looking at all these studies is when we combine regional analgesia with general anaesthesia and compare that to regional anaesthesia. And again, we know there are potential issues with this. For example, the POISE trial was the first to show, and subsequent meta-analyses have confirmed that when we combine epidural analgesia with general anaesthesia, there appear to be an increased number of cardiovascular complications. And when we're looking at regional anaesthesia alone, we have to consider neuraxial compared to peripheral nerve block techniques, or do we combine the two? We know that neuraxial clearly has hemodynamic potential issues. If we're doing a peripheral nerve block, are we talking about an ultrasound-guided block versus a nerve stimulator block? There is no doubt that one of the most important things is the operator, because the success of the block makes a big difference to the success of the potential outcome. And we know, for example, the dose is important as well in neuraxial anaesthesia when it comes to looking at outcomes after hip fracture surgery, because it affects the hemodynamic stability of the procedure. So there's lots of potential variables within the anaesthetic alone. An area that hasn't been studied as much, and I think is really potentially quite exciting, is comparing the effect of peripheral nerve block anaesthesia versus general anaesthesia, because we then take away all the potential hemodynamic issues of a neuraxial technique. But there's actually been very little work done in these two in this field. When we then think about all the variables, then clearly the best way to account for all these variables is to do a randomized controlled trial. But general anaesthesia and regional anaesthesia are both extremely safe, and that means that finding serious complications is difficult because they're very rare. And if complications are rare, then we need to usually move to doing meta-analyses. But everyone is aware of the potential between comparing lots of different outcomes and including these in a meta-analysis. This was just one study by Vincent Chan's group looking at all the different outcomes in shoulder surgery studies, and they found over 80 different primary outcomes, which shows why it can be difficult to do good quality meta-analyses. One of the other issues is, even within regional anaesthesia, is making sure that we're using the same blocks. This has been an issue in some of the trials looking at knee surgery, comparing adductor canal and femoral triangle, and people are not clear in the study which type of specific block they are doing. And certainly there's been a recent project between ASRA and ESRA to standardise the nomenclature in fascial plane blocks in the abdominal wall and the paraspinal and chest wall regions, so that will help a little bit as well. If we can't find an answer with meta-analysis, then we have to move to prospective and retrospective studies, and clearly we're aware of the potential confounding factors when we look at data from these, as well as the data from meta-analyses. So when you take all that into account, then never mind comparing apples and oranges. When we have all these different variables with the patient, the procedure, the anaesthetic, and the different ways of studying it, then clearly we can have a complete fruit salad when it comes to trying to determine what are the outcome benefits of regional anaesthesia compared to general anaesthesia. And the next question is, what are the outcomes that we should be studying? Dave Johnson and Lloyd Turbot are colleagues of mine in Regional Anaesthesia UK, and they wrote this recent review article about success, and they split the categories into patient, population, healthcare, and training outcomes. We wrote a paper almost 3 years ago now in BG Education, and we split ours into patient outcomes, surgical outcomes, and institutional outcomes. Now, each of the topics on this page, really you could spend all lecture talking about, so I'm just going to have to go through them quickly. There's no doubt that regional anaesthesia and analgesia reduce acute pain, and if you look at the guidelines, which are procedure specific, then regional anaesthesia and analgesia feature in all of these for each individual procedure they look at. When it comes to preventing persistent postoperative pain, the data is less clear. This meta-analysis suggested that regional analgesia reduced pain after thoracic surgery and breast surgery, but there's been other meta-analyses since that, particularly looking at breast surgery, show that persistent postoperative pain isn't reduced by regional analgesia. There's no doubt that regional anaesthesia reduces postoperative nausea and vomiting, and that's included in big international consensus guidelines. When it comes to cognitive function, I've split this into short-term delirium and longer-term postoperative cognitive dysfunction. When we discuss delirium, then all the evidence would suggest that we should be reducing pain and reducing opioid consumption in order to reduce delirium. But interestingly, even though regional anaesthesia should in theory be good, there is no evidence that regional anaesthesia, or good evidence that regional anaesthesia reduces postoperative delirium compared to general anaesthesia, mainly because no doubt delirium is multifactorial. There is reasonable evidence that using nerve blocks in hip fracture surgery does reduce delirium by reducing opioid consumption. There's no evidence that regional anaesthesia reduces postoperative cognitive dysfunction compared to general anaesthesia, again because this is multifactorial in nature and most likely reflects the magnitude of the surgery in particular, which is what determines POCD. Cancer recurrence, everyone will be well aware of the retrospective data for breast, prostate, and colonic cancer that regional anaesthesia and analgesia may improve outcome. But the latest, or the only prospective data, which has just been published by Donald Buggy's group, did not find any benefit of regional analgesia and anaesthesia. When it comes to morbidity and mortality, I like to look at the work by Stavros Memsoudis, who has published a lot of work on big data. This is an analysis of over 1 million patients combined having truncal and lower limb surgery, and a big group of patients, as I say, looking at contemporary data, comparing general to central neuraxial block alone, or general combined with central neuraxial block versus general anaesthesia alone. But all these operations were combined together, so it's not procedure specific. But it clearly gives you a large number of patients, but with this large number even, they still could not see a difference in mortality. And that echoes what we know from the multiple randomized controlled trials and meta-analyses in hip fractures. So I feel we have done enough of this sort of work now, which shows that certainly for hip surgery, it's not what anaesthetic you do, it's the way that you do it, and make sure you provide a nice hemodynamically stable anaesthetic. When it comes to morbidity, there is data from both randomized controlled trials and these big data analyses that combining central neuraxial block with general anaesthesia compared to general anaesthesia alone reduces pulmonary complications, thromboembolic events, blood loss, surgical site infections in some studies, as well as a short reduction in length of stay and ICU admissions. But what is important, I think in particular, is that if you can do the operation under central neuraxial block alone, which clearly is not possible for all operations, but the benefits are better. Look at the improvement in all the complications in green compared to when it's combined with general anaesthesia. So the important message is, if we can avoid the general anaesthetic, the complications seem to be even less with regional anaesthesia. We have to be careful because the data in this study is primarily made up of lots of prospective database analyses combined with some randomized controlled trials. So clearly, although the team have tried to account for confounders, there are potential issues with this data. Nevertheless, with such a large number, I think it's important and we need to take notice of that data. Certainly, Memsoudis' group again is in charge of the Icarus guidelines, and the guidelines for lower limb arthroplasty, so hip and knee surgery, recommend using neuraxial rather than general anaesthesia for the procedure. So I've shown you briefly some of the short-term mainly benefits of regional anaesthesia and analgesia. I think mortality, feel we have studied enough, and certainly it's difficult to show a benefit because of the safety of regional and general anaesthesia and the rarity of complications. I think what is important to ask, though, is I've shown you these benefits in terms of asking the question, is regional better than general? If we turn it around, there's no evidence really that general is better than regional in any of these outcomes at all. And that's something that we need to bear in mind. The other thing we need to think about, however, is, are these the right outcomes to study? I like this paper here, even though it's 5 years old. I still think it's an excellent paper by the Compact STEP group, which is aiming to standardise endpoints in perioperative trials so that if we have a core outcome set, that will make it better for when we do meta-analyses. And some of the outcomes which they suggest that we need to be looking at are now starting to come into literature for the regional anaesthesia trials, but in particular for patient comfort, we're thinking of quality of recovery scales, sleep quality and disturbance, and perioperative anxiety and stress. If you look at a quality of recovery scale, you can see that some of the features of that are not particularly amenable to regional analgesia and anaesthesia, but nevertheless, there are now papers coming through which suggest that quality of recovery is improved by regional anaesthesia and analgesia. Sleep quality and disturbance is interesting because clearly if we have rebound pain, which is one potential issue with regional analgesia, that if patients start to wake up in the middle of the night when the block wears off, that could be a problem. There are clearly ways around that in terms of prolonging the block and using catheters. And similarly, perioperative anxiety and stress can be reduced with sedation or using other non-pharmacological methods such as music. But again, more work needs to be done on that front. Patient-centred outcomes are clearly of utmost importance. And again, it might be difficult to see why regional anaesthesia and analgesia will improve some of these longer-term outcomes, but work needs still to be done. There has been a significant amount of work looking at functional status, particularly in orthopedics, for example, where we know that the analgesia provided by a nerve block improves physiotherapy and improves early mobilisation, even up to 6 or 8 weeks, despite a short-term block. But if you look at the data then for 1 year outcomes after a hip and knee arthroplasty, for example, there's no data to suggest that regional anaesthesia and analgesia improve 1 year long-term functional outcomes. Where we have shown a difference is in arteriovenous fistula surgery. There are several international guidelines which suggest that we should be using regional anaesthesia rather than local anaesthesia for arteriovenous fistula vascular access surgery because of the vasodilatation that occurs around the time of the operation with the nerve block. And that is partly based on some of the work that we have done. This was published in The Lancet in 2016. We showed that a brachial plexus block rather than local anaesthetic improved 3-month patency for an arteriovenous fistula. And we've subsequently published the 1 year data that even at 1 year, the patients who had a brachial plexus block had better functional patency in their arteriovenous fistula, and it was cost effective compared to the group who had a local anaesthetic. Ultimately, however, that was a single-centre trial, and we are currently doing a multi-centre study funded by the National Institute of Health Research, looking at the same techniques, brachial versus local anaesthetic, and looking at the 1 year functional outcomes, and that will report hopefully in 2025. There is data to suggest that regional anaesthesia improves length of stay and prepares gets patients ready for discharge earlier as well. One thing that isn't perhaps talked about in some of these outcomes is using regional anaesthesia for environmental benefits. And we know for sure that clearly TIVA is better than volatile anaesthesia. And it would make sense that regional anaesthesia is better than both TIVA and certainly volatile, but actually there's not been any life cycle analysis done to confirm that regional is better than TIVA. I do think it will be, but it's not been proven yet. So in terms of conclusions, when it comes to our choosing wisely principles, it's always a balance between benefit and risk. You will probably be aware of the British Olympic cycling team in 2012 and other sporting teams and industries that used the principles of marginal gains, and that had a big success in terms of the British cycling team, certainly in the Olympics. And I like to think of regional anaesthesia in the same way. Some of the benefits are small, some of them are potentially big in terms of pain and nausea and vomiting, which are important really to patients and, of course, morbidity benefits. There may be some small institutional gains. There's certainly less evidence about long-term benefits, and I think there will be clear benefits of regional anaesthesia once it's studied in depth. And these marginal gains all come together, to my mind, to show that regional anaesthesia is more favourable compared to general anaesthesia. I think in terms of future studies and important take-home messages, the data would certainly suggest that using regional alone rather than combining with general anaesthesia is where most gains are to be made. I think, or I wonder, whether there will be even more gains with good quality peripheral nerve block rather than neuraxial blocks, where we have the potential hemodynamic issues, which we see in hip surgery, for example. We have to think, are there specific patient groups, for example, those who have more comorbidities, who will benefit more from a regional anaesthetic compared to a general anaesthetic? And similarly, are there certain procedures which benefit most from regional anaesthesia, such as arteriovenous fistula procedures? I think when it comes to looking at all these endpoints, then part of that involves education of patients to know that they can have these techniques under regional anaesthesia. We need to educate the surgeons, of course, as well. And we have to, of course, educate ourselves, because I think the better we get at doing the blocks, the better the outcomes will be. But certainly we need to study that, and we need to study it using the appropriate endpoints that I've been discussing earlier on. And hopefully, when all that comes together, we might see some more benefits still of regional anaesthesia compared to general anaesthesia. Thank you.